Hello, everyone. Hello, hello. Alexis Madrigal here, one of the co-founders of the COVID Tracking Project. Thanks for coming to this training call. We are going to do basically what we've done in the other ones. We're going to bring on the true experts in these data sets to help you out, and then we will do questions at the end. So we'll drop them into a question doc, and then we'll kind of MC at the end. So first, we're going to start out with the long-term care facility database, turning it over to Kara and Artis. Thanks again for coming.
Hello.
Hi, everyone. Hey, I'm Kara Oler.
And I'm Artis Chiriskis.
And we run the long-term care tracker here at the COVID Tracking Project. And today we're going to introduce you to the CMS COVID nursing home data set. As you know, we're stopping collection this week. And so we want to show you some comparable data sets that you can use. So we'll talk a little bit about the CMS data set, what it contains, how you can use it, what it's missing, and how to move forward with it. So the data that we collect here at COVID Tracking Project, and let's go forward. Hold on. Yes, there we go. The data we collect here at the COVID Tracking Project is all from state dashboards. And long-term care facility resident and staff deaths account for 35% of all COVID deaths in the United States. And so, you know, what we know, I mean, is behind all of this data and numbers we're talking about today are people who have lost their lives in these facilities. And it's really a story about also these facilities that were not prepared for the pandemic. So next slide. We gather data down to the facility level when available. This is a map that you can find on an individual state page on our site. The problem is not all states offer facility level data. Next slide. So within our data set, we gather these different data points here. We have resident and staff cases, resident and staff deaths. Some states combine resident and staff together. We also gather data every Thursday and publish it on Fridays. We offer the name of the facility and location and type of facility when possible. And then also we manually match up the federal ID, which we'll talk about later, which is really an important key to the CMS data set. Unfortunately, no states provide that, so it's all manually matched up. And then we also gather outbreak status, which means if they currently have a COVID case actively at a facility. Okay, next slide. We run 4 data sets for the long-term care COVID tracker. We have cumulative, which is total cases and deaths. We have outbreak, which is active. We have an aggregate, which is basically cumulative. And then if states only report outbreak, such as Florida only reports outbreak cases, then we carry the highest case ever, which is a drastic undercount, but at least, you know, closer of a representation than outbreak. And then we also have a facility level data set for every state that provides that data, going back to May 28th when we started gathering data. Next slide. So there's a data set that we're talking about now, which is very similar and much more standardized than what the states provide, and that is the CMS's nursing home data set. The only issue, well, one of the issues is that it represents fewer people. So next slide. According to the National Center for Health Statistics, in a report released last year, there are about 1.3 million residents that live in nursing homes, and then assisted living and personal care homes, residential care homes, have, you know, a little over 800,000. And the CMS data set does not cover this 800,000 residents that live in these other facilities that are largely regulated by the state. Nursing homes, and there's a word used interchangeably for nursing homes, which is skilled nursing facilities. Those are regulated by CMS, and so those are the facilities that are represented in this data set. Next slide. So what is the CMS COVID-19 nursing home data set? The next slide. The CMS data set has 120 data points It's incredibly standardized. It includes resident census, current licensed bed count, PPE supply, suspected cases, confirmed cases, suspected deaths, confirmed deaths. And next slide. It was first published on May 24th, 2020. It's reported on a weekly basis, but as we'll talk about in a minute, there's no backfill required of any of these facilities before May. Next slide. Facilities can report through this long-term care facilities COVID module. And there are 3 types of facilities that are eligible to report. Skilled nursing facilities and nursing homes are required to report to it at least weekly, but they can report daily. Assisted living facilities and residential care facilities, those facilities that represent about 800,000 residents that we talked about a minute ago, they can report to this module, but it's not required. And then also care facilities for the developmentally disabled are also eligible to report here. The only data that's made public from this COVID reporting module is the nursing home data. And that's what you find in CMS. So just an overview, next slide. When you look at this data, some data to pay attention to within it is bed count and current resident census. So what we know about reporting is that facilities enter in licensed bed count right when they start reporting as a facility, and that number stays static typically. Current resident census can change every week, and so you might find that those numbers are sometimes even larger than bed count, and that can be due to a number of reasons, like maybe COVID residents were all cohorted together, and so you'll end up with a higher number of residents than licensed beds. That was something that was a mystery to us early on, that now we found out that's what's happened. And then some of these other elements that we've talked about before. Let's go into what's missing. So the first death in a long-term care facility in a nursing home was at the Life Care Center in Kirkland, Washington. And that was at the end of February, and nearly 3 months later, or early March, and nearly 3 months later is when the CMS nursing home data set was released on May 24th. And so one of the major issues is that, next slide, and this is a slide from one of the training videos for the reporting module. One of the major issues is that there's just no data that's required to be reported for those first early months in the pandemic. Facilities can, it's optional, but this ends up creating some discrepancies between what you see and what the states are reporting and what you see and what CMS is reporting. So for example, on the next slide, we have, this is the very first facility level report with data that Connecticut released. This was released on April 16th. And so in this data, they're reporting 375 deaths. And so an issue with this is that when CMS reports, we don't know if those facilities and those 300 some odd deaths are represented in the CMS data set. And so if you go to the next slide, you can see, this is a little visual of the data sets reported by the state, by Connecticut, and also reported by CMS, which is represented by the blue line. And you can see that CMS deaths are a little over 800 below what the state is reporting. And so we went back and looked at some of those facilities, and a number of those facilities are still reporting those lower deaths. So we can tell that they didn't backfill over time. Not all, but some. Next slide. So as we mentioned, another thing that's missing is it's only nursing homes. And on the next slide, we can see kind of what that means. So with the state data set that we gather, currently there have been 172,000, nearly 173,000 resident and staff deaths. And the CMS data is reporting 129,748 deaths. So it represents about 43,000 fewer COVID deaths than what the states are reporting. Next slide. So these are a few things that CMS calls out about what the limitations are to the data set. As we mentioned, that it's just nursing homes, that the first deadline for reporting was May 17th, and so it's optional to backfill. Availability of testing with all COVID cases means that we, confirmed cases sometimes depend on the availability of tests. Facilities also can change their cumulative data at any time. So you may have data change in the time series. So it's not static. And also sometimes CMS will come in, and if they see anything that looks extremely obvious, like someone typed an extra 0, they'll go ahead and replace that, I believe, with an N in the data. And that means that there's something that wasn't quite right that they identified. The last thing that isn't on this slide, but they also say that for that very first week, you don't want to use the first week of CMS data for time series for comparison, because they were still figuring out the reporting, and it has all of those earlier cases that were reported. Okay, so how does CMS compare to CTP? So let's look at this map on the next slide. And what you have here on the left is a visual representation of every facility that we have seen in CMS or in the state data set that has had a COVID case or death. And on the right, we have the facility level data that states report. So we can zoom in on that on the next slide. And so this is a real limitation to the state data that we gather. So you can see that states like Washington, where the very first cases were, Montana, South Dakota, Nebraska, Arizona, a lot of these states don't report and have never reported facility level data. And so to fill in that gap, we can look at CMS data and at least have some idea of what occurred in those states. So a state like Arizona, where the state actually went to court, a court ruled that the state could keep the nursing home data and long-term care data private. The only means to have that data available is through CMS. For our own data for that, we use data from Pima County and Maricopa County, which represent Phoenix and Tucson metro area, to at least try and get closer to the impact. Next slide. And so here you see, between these two data sets, so the share of total COVID deaths for the CTP state reported data set is 35%. And, the CMS data set is 27%. And so I just wanted to do one last little comparison before we get into how to use it. And so here we lined up every state, and the blue line you can see is the state reported data, and the orange line is the CMS reported data. And so this is total cumulative deaths reported by the state compared to CMS. And what's strange in some of this data, just in these preliminary evaluations, is that it looks like 12 states are reporting lower deaths than CMS is. And since we know that nursing homes are only a subset of the total long-term care facility COVID cases and deaths, this raises some questions. So this is just something to point out as a thing to potentially look at when looking at this data. So if you go to the next slide, you can see that California, basically the blue line and the darker orange line, that's the orange is representing nursing home data in our data set, and it lines up basically perfectly with CMS. And in Ohio, they don't distinguish between nursing home deaths or assisted living deaths, so this is just total. And you can see that the CMS data is reporting more. And we're really not sure why that's happening. It's just kind of an open question worth exploration. We know, there are always different things you can look at. We know in Ohio, for example, they didn't start reporting long-term care cases until mid-April, and that they've said that the health department said that there are 369 deaths that the state is not reporting to do with long-term care that happened before that date when they started reporting. So now we're going to explain a little bit about how to use it. And I just wanted to put this up here and say, both of these data sets are far from comprehensive. And, at this point, we've had now more than 2.5 million residents and staff that have been vaccinated, and we're starting to see major reductions in deaths in these facilities. And we continue to see these numbers to drop and hope we will. But I think it's just important to think about using both of them to try and see the full impact of this pandemic on long-term care. Thanks. I'll turn it over to Artis.
Thanks. All right. So Kara walked you through what the CMS data set is and both its limitations and its strengths. And so I'm just going to do a brief little thing on how to actually use it and pull the data, because it turns out the CMS data set is enormous. It's 60,000 plus rows, 120 columns, and it keeps growing every week. So you can't pull it. Like you can pull about 1,000 to 3,000 rows, but that's it. So if you're trying to do a state or even 1 week, it's going to take a couple different filters and exports to try and pull it all out. So what you have to do is you have to break it down either by state or by week or by whatever metric you want to research. And in our 101 post that I believe is live right now has a user guide manual on how to pull the data using this filter, or if you want to use the API version that datacms.gov provides. There's some steps there. There's some fancy GIFs like this to help you walk through it, because this is a massive resource, but it is somewhat hard to access, and we want to make it as accessible as possible. The key thing, as Kara had mentioned earlier, that we integrated into our LTC data set was the federal ID number. And the real importance with this is that it's allowed us to cross-check everything we have in the state level that we've collected from states to compare with what the federal government's released. But not only that, it allows us to cross-reference with other CMS or CDC data sets surrounding nursing homes. So there are 4 other data sets that we definitely lean towards. There are a couple others, but if you want to crosswalk using the federal IDs and using the magical VLOOKUP formula and then parsing them together, you can look at kind of provider information, which are star ratings or staffing hours, or if it's a for-profit, nonprofit nursing home, and then see how cases or deaths correlate to that. You can look at penalties. I will say that if facilities did not report data to the CMS, they would get fined as well. So there were consequences for not reporting, but it's not entirely clear which facilities were penalized for this and how that worked out. Then you can look at ownership. You can kind of look into nursing home chains or owners, or if they were LLC or nonprofit, back to that. And then quality of resident care is like a combined out of 100 score that uses staff ratings, staffing hours per resident, and all these other kind of quality of care measurements, and they use that as a metric. So either way, point being is that there's a lot here. The federal IDs are kind of the key to like unlocking a ton of analysis. And on top of that, if you want to understand what states are reporting, you can use our data set because we have those federal IDs matched up and bring it all together. So bringing all that in is all of that Kara and I just talked about is what has been the impact of COVID-19 on long-term care facilities. And now that we're in the vaccination part, it's been what is the response to that impact, and how have vaccinations been distributed and administered accordingly. So luckily, there is a wonderful program that was built up called Federal Pharmacy Partnership for long-term care facilities, and it provides end-to-end management of COVID-19 vaccination information. And through this, has actually, what was supposed to be one pipeline has somehow also built out 3 different potential data sets. So I'm going to walk through, starting from the back end with CDC and working backwards about what data is available, where that data is coming from, and then what at the end you can use to try and match up everything and make more sense of it. So starting with CDC, the big federal data producer. So they show data on their dashboard at the national level and the state level. So at the national level, they provide doses administered and the number of people with 1 or more doses or 2 doses, or basically fully vaccinated. Luckily, at the national level, they split it off by residents and staff so you can get that sort of measurement and understanding about who's getting it. Unfortunately, at the state level, at a more granular level, the CDC does not split it out accordingly. But you can still look at how many were administered by state, at least here, and they provide you the option to download it as of that day. So of all the information on the CDC dashboard, this is the only spot that you can download vaccination information for basically more than 2 cells. And if you look at the map, the other key detail there is that West Virginia opted out of the pharmacy partnership program and decided to run it all internally. So that is why they're missing on the map. And in case you do analysis and you're like, where's West Virginia? It's because they're not included. So then how does this data get to the CDC? Tiberius data collection. So Tiberius, the Department of Defense actually in their memo about Tiberius makes the joke that Captain James Tiberius Kirk from Star Trek is like what it's slightly named after. And I guess it's also in line with Operation Warp Speed. There's kind of a whole Trekkie science thing going on there. But anyway, the point being is that Tiberius is the central software platform that COVID-19 vaccines are running through. And all that information is running through it from when it's distributed all the way to the CDC, and it's through this system. So it's required that whenever a dose is administered, it takes 72 hours, that has to be reported within 72 hours. So it's a fairly responsive system in understanding what's happening. However, Tiberius data is not published. It's not available, except in the case of South Carolina, which publishes it daily and has been publishing it daily since early January. And they've only published the Moderna vaccine allocation. And in it, they have a whole note that says, this data is directly from Tiberius. It is not from our Department of Health. Use it as you will. And so from that, we can see that the Tiberius data includes the pharmacy name, facility name, where it's from, number of beds reported in each facility. Resident and staff is split off separately, also with first and second dose split off separately. So this was like, to our knowledge, South Carolina is the only state that reports it publicly on their website. Colorado and Nevada have provided it to us by email. And if there is anything that we wish was more available, it would be this information, because it is so granular that you can see the pharmacy, you have the facility name, which is then something you can match up with the CMS facility IDs and state data that we've collected and that the CMS has. So you can make more connections there. So the big crux of the whole pharmacy partnership program are the pharmacies, and they also release data. So CVS and Walgreens, the big two that are kind of really the heartbeat of the program, release data every day, except for CVS is only on weekdays, Walgreens is daily, and they present it as a couple of metrics, but they don't split it off by staff or resident. They do split it by if it's a skilled nursing facility or if it's assisted living. So then again, you have another way to potentially compare with CMS data. The other thing is that they split it off by jurisdiction, which interestingly will have Chicago be independent from Illinois. So if you're going to do analysis, you have to combine those two. So what metrics do they use? They use the number of facilities within a state that's partnered with said pharmacy. And then for each of those facilities, the pharmacies will run 3 clinics. The first, each one is basically to administer all the vaccines they have to residents and staff in that facility. And they do it in 3 because if they miss anyone in the first or second, then they have a third one to kind of shore it up and complete it. So they list that information as percent. So you can see like Clinic 1 in Illinois is 100%, Clinic 2 is like 98%, Clinic 3 is about 50% or something like that. So you can see the progression of states in vaccinating all their facilities according to CVS or Walgreens. Then they provide the total administered vaccines, and then they also provide activation date. So the pharmacies were unable to begin clinics until states gave them the go-ahead. And because of this, there was kind of dissonance or not dissonance, there was confusion as to when vaccines were going to these facilities or who was doing it, who was holding it back. And so CVS and Walgreens have published this information to just say, this is when we could begin. And it also provides a start date to understand when we might be able to do some sort of time series or lag data analysis as to when vaccines were being administered. Other pharmacies, there's a ton of other pharmacies that are included in the program. There's 40,000 nationwide, but here's a list of other kind of orgs that may be providing data. And then to sign up and how you become a facility that's connected to these pharmacy programs is in November, you had to have signed up for the pharmacy program. As of right now, that sign up for that program is closed. Alternatively, there's multiple ways that they can still get vaccinations and sign up for that. There's also still an opportunity for LTCs to sign up and become long-term care pharmacies, which grants them basically more independence in administering vaccines amongst their staff, with their staff or subcontracting staff into it. So back to this is the whole pipeline of information that runs largely through Tiberius and ends up in the CDC. And at the end of it is that we end up with 3 data sets. We have the Tiberius data set that we can pull from South Carolina. And since you have Colorado and Nevada providing it, maybe other states, but that gives you the facility level information and staff and resident split. CVS and Walgreens releases data by the state or jurisdiction level, and you can look at nursing home, assisted living, and CDC is just the blanket of every state. So each one you can kind of piece together because Tiberius provides whether it's a CVS or Walgreens pharmacy, so you can kind of combine and compare those two and see how those numbers match up. CVS and Walgreens combined, you can see if CDC's vaccination numbers for each state match up or if it's one or more or less the same or not and what's going on there. So really between the 3 of these, at least you can look at more granular data with Tiberius, you can look at granular data by pharmacy, and then you can look at the national picture and try and make sense of how vaccines are being spread throughout the US to long-term care facilities. So potential questions, I guess to leave you with is which facilities were prioritized, how is it being distributed across staff and residents or facility type, what are the differences between CDC's reporting at the state level, and then the question of how long did it take vaccines to take effect. And as we've said, we're viewing it right now in our data, but there's always more analysis needed. And lastly, I guess to kind of tie it all together, what are some recommendations and things we want to look for in both the CMS data set, but also in what we know about from the vaccine data sets. So with the CMS one, it's about getting more historical data all the way back to January 1st, as Kara had pointed out that CMS started in March 24th, March 24th. And then also we would recommend developing a comprehensive reporting system so that all long-term care, not just nursing home, is surrounded under federal guidance and understanding and reporting, and then provide current facility counts and population counts so we can understand what % of facilities and the population were impacted. And then lastly, facility level vaccination data would be really essential, especially in comparing with CMS's data, which also goes at the facility level. Thank you.
Thank you, Artis and Kara. And boy, like for those of you who have been working with this LTC data at all, you probably know how difficult it is to bring this data in, how hard it has been to work with. And thank you so much for getting the data in and also putting together this presentation for folks. Thank you, Kara and Artis. And now we'll go to another complex and difficult data set. Do we have Alice on the line?
Hello.
Take it away.
I'm Alice Goldfarb, and I want to start by thanking all of the folks who have been part of making this data available for the past year and have helped make sense of it. And I want to look a little at the federally available data, which may be able to help people continue to think about how this pandemic has affected different communities in different places differently. Next slide, please. So to start off, looking at the federal COVID-19 data, including race and ethnicity, which comes from several different places. So starting on the left, aggregate data from the COVID data tracker, case surveillance line data, COVIDnet, which has a sampling of data about hospitalizations, and then National Center for Health Statistics data sets that come from death certificates. And next slide, please. And looking at the same information the other way, looking at it by metric rather than by source. Vaccination data only comes at the national aggregate level. Testing data is not made available at all. Case data comes at these two scales, which I will talk about in a moment, both national totals and then by de-identified person, so very macro and very micro. Hospitalization data, the COVIDnet data is this sampling of hospitals that serve 10% of the US population in 14 selected states. So it's not at all representative, but is the only available hospitalization data that includes race and ethnicity data. And then information about deaths is available everywhere that information about cases is, with the addition of the NCHS, the National Center for Health Statistics information. Next slide, please. Looking at the national and individual scales for the cases and deaths data is a good place to start thinking about how to compare what's available federally to what we've been able to collate at COVID Tracking Project using data we've collected from states. Next slide, please. To begin with, the CDC's COVID data tracker shows a bar chart of cases and deaths by racial and ethnic group, and allows for the possibility of seeing the percentage of cases in each age bracket for each racial or ethnic group. There's no information about what jurisdiction reports this data, and so it's impossible to know what these numbers should or could be compared to, what is the underlying population. This is updated daily, and no record is included of past days' data, and the data that goes into the bar chart is available as a CSV. So it's essentially two records: today's case, or yesterday's cases total and yesterday's deaths total, and is a snapshot in time. What we've been able to collect at CTP has been from what's reported by states, and we've updated twice a week, though the states themselves may report more or less frequently than that. The data from each of our twice weekly updates is available with all, so all the historical data is available with records for tests and hospitalizations, as well as for cases and deaths where those are reported by the states or territories. And I will say a little bit more about the ways that race and ethnicity are reported momentarily. And from the entire other end of the scale, from the national aggregates, are these case surveillance files. Artist was talking about how large the long-term care data set can be. And the case surveillance file has one record for each de-identified person. So as of, and this is updated monthly, so as of the end of February, there were 21 million records. So again, this is publicly available data, but is also super unwieldy and does not make immediate takeaways from the data readily available for someone who cannot go through the work of downloading these files and finding ways to work with it. So the publicly available data set, there are two case surveillance data sets. The publicly available one has race and ethnicity, but no information about where this case happened. And the restricted access data, for which people need to request permission, includes both state and county of residence. And so Goldilocks style, I think both of these scales are interesting, the individual level and the national aggregate, but I would like to see federal data made available in a way that has a little bit more detail than the national and somewhat less than the line data, for someone who isn't going to download several CSVs and combine them and analyze the millions of records. Some state or county level compiled data, I think, is very important to make available. Next slide, please. This is a snapshot of the National Center for Health Statistics, the NCHS data sets, which are based off of death certificates. And last week's presentation and a previous blog post explain in more detail the differences between how this information and other information about COVID deaths is collected. And I'm not going to go into great detail about these data sets, but I do just want to reiterate my theme throughout today, which is that the data sets are not at all set up to be compared to one another. These 9 data sets from NCHS, they're all from the same agency. They all ostensibly are about the same information, and yet the choices about what to include, including what categories, what jurisdictions, how often to update, are very, very different. And so it's very hard to make any comparisons between the data presented. Next slide, please. The case surveillance data is unwieldy, but probably most able to be used to compare to what we've collected from the state reporting. One of the many ways that this data differs from what is collected from the states is that the categories which are reported are not at all consistent. At this point, many of the race categories match, but many more do not. So some states will report standard categories on their dashboards, but not report some of those same categories to the federal government, or vice versa. New York State, for example, does not report any COVID-19 case data with race or ethnicity information publicly, but does share it with the CDC. And categories that we use in our data set, and which the CDC uses mostly, with some exceptions, are the same that are used by the census, so that we are able to compare to population data that the census collects or that American Community Survey makes public. And these are the categories that are used, hopefully, by all federal data as outlined by an Office of Management and Budget directive, which was updated in 1997. Next page, please. One place in particular where the states are making different choices about how to present data is how to deal with these 2 categories of race and ethnicity. Unfortunately, we don't know for the most part how states are acquiring their data or what question they are asking at testing centers. But at the top of the slide is what's included on the CDC's worksheet, which asks separate questions about a person's race and ethnicity. So everybody who is, having a COVID test done, everybody who is being put in the system will have some answer for ethnic group and some other answer for race. And then looking below, there are 3 different ways that states choose to report this information. So some states, as Mississippi does, report both. So somebody who has selected, and I just want to make sure that I'm getting categories that Mississippi actually includes, somebody who is both Black and Hispanic, that is included, as well as somebody who is Black and non-Hispanic. So you can see the breakdown for both race and ethnicity. Some states, as Delaware does, treat everybody who has selected Hispanic or Latino, or however that state, whatever category name that state uses, will report everybody who has selected Hispanic or Latino as Hispanic or Latino, regardless of the race category they select. So anyone who is white and Hispanic will be put in Hispanic, and anyone who is Black and non-Hispanic will be put in Black. So anyone who has selected Hispanic is in Hispanic for the states that combine race and ethnicity. And these combined race and ethnicity categories are the way that the CDC data is presented. And some states report 2 separate tables, 2 separate charts. Pennsylvania, for example, will report people, one breakdown of the ethnicity categories and a different breakdown of the race categories, and you have no way of knowing where the overlaps lie. Next slide, please. So as with everything else, this leads to wild inconsistencies. There are 20 states that report race and ethnicity combined, as is done in the federal data. Another 24 states report race and ethnicity separately. So there's one table for race and another table for ethnicity, which means that for those states, it's much more difficult to compare the data that we're collecting from the state with the data that the CDC makes public, because somebody who is Hispanic and Asian does not show up, will show up only as Hispanic in the federal data. And so we don't know where inconsistencies in the data are because of these different categorizations and where they are the result of something else. Of course, even that is not enough inconsistency for the race and ethnicity data. And so some states will report different metrics with different choices. So we'll report race and ethnicity combined except for vaccinations, or DC reports race and ethnicity separately for cases and vaccinations, but reports them combined for deaths. It is very difficult to have either some sort of cohesive national picture or to be able to compare the state reported data and the federal data because of this. Next slide, please. So looking at the COVID tracker data from CDC, race or ethnicity is known for fewer cases and fewer deaths than what is reported from the state data. And what we have found throughout this project is that both that the data is much too incomplete and inconsistent, and that the data available indicates major inequities in the pandemic's effects. And while the federal data is different both in category and in value from what we are collecting from the states, I think that the same two things are very apparently true in that data, that too much data is missing and what data is reported shows ongoing disparities. Next slide, please. I will turn it back over to Alexis.
All right. So thank you again, Alice, for that too. Hopefully you got a sense of the the true complexity of both of these data sets, which seem to me to have distilled the most intense versions of the problems of stitching together state data into national data sets, generally speaking. I'm going to take a look at these questions here and feed them to you all. And we are looking at, here we go. Let's start with, it's a pretty specific question from Jeff Kelly Lowenstein. And we have something of an answer here, which I will sort of give you a piece of it here, and then Kara and Artis can take it from there. So the question is, how much of the 43,000 difference between COVID tracking projects and CMS totals are from nursing homes, and how many are from the other two facility types in the CTP project? And the short answer to the question is that we can't do a direct comparison at the national level because most states don't report nursing home type deaths separately. But we can dig in state by state for the states that do have nursing home data. Kara, would you say that is, and Artis, would you say that's the right answer there?
Yeah, that's totally correct. There's just no way for us to know. We can really only trend a number of states. I don't have an exact number of how many. I think it's around 23 or so that actually name nursing home as a facility type. So it's unfortunately just not a thing we can call out.
We also had another question that was about where hospitalization data, generally speaking, could be found. And I just wanted to direct you to the COVID tracking site, where we have some 101s on working with hospitalization data. And we also had a training on how to work with that stuff. So take a look at the site and you'll see some more of those components there.
I wanted to mention too, just really quickly, that
Sure.
we are going to post the slides and recordings along with links to all of the blog posts that have gone along with these trainings on the site. So if you missed one of the first two recordings, you will absolutely be able to see those. And then we have, as I said, we already have blog posts on the site kind of summarizing those previous presentations.
And there was a follow on hospitalizations too, and Karen Artis, I don't know the answer to this, so I'll refer to you. Are there numbers on resident and staff hospitalizations in LTCs?
No,
Yeah, I didn't think that I had seen that.
at least not that we know of. There certainly could be, but not in the data sets that we look at every day.
Cool. Alice, we have a couple questions for you. One is, are you aware of efforts on the part of the federal government to improve race and ethnicity reporting standards across states so this data becomes more useful, comparable? I can answer one piece of this, which is that the federal government did require laboratories to gather this data. That was, I can't remember exactly the date when that went into effect. It was late in summer.
Beginning of August.
Beginning of August, yeah.
The guidance came out in June, and then it was beginning of August.
And Alice, I mean, did we see any major changes in state reporting? Yeah. We were really hopeful. Yeah, we were really hopeful that we would see things change, but we didn't. In terms of other things, you know, I do you know of any other efforts aside from just requiring the?
I don't know, and some of what I would love to know more about, and I hope that other people will look into as well, is we don't always know what data is available and is going to the federal government, and what things aren't being made available and what things aren't being recorded. And those are two totally different things that we've seen a bunch of places that, you know, the data is obviously there because it's getting to CDC, but it's not going onto a dashboard. And so it may well be that a lot of this data is around and just isn't being made public at the moment.
Another question: does the 54% of deaths with known race come from Nchs death certificate data or case surveillance data?
It comes from the case surveillance. It's what's in the COVID tracker, which, as far as we can tell, is coming from the case surveillance data, though it is updated daily. Well, that case surveillance data is updated once a month, but we think that it's coming in from the case surveillance data.
Gotcha. That is our questions that we have so far. I'll give you like 30 seconds to type one quickly into the box if you've got any others. Otherwise, we will give you a few minutes of your day back. Give you like 30 seconds here just to wrap up. Again, while I'm vamping here shortly, do take a look at the blog. It's no longer called the blog on COVID tracking project. It's called Analysis and Updates. So take a look at Analysis and Updates. We have posted an ungodly amount of things about this, and I also just want to thank the teams that presented here today. I mean, putting together the knowledge that has been extracted from the federal government using what we were extracted from the states is like a very, very difficult task, and I really appreciate it. Take one last look at our question set here. One question is Peter Walker going to publish the new 4-pane on a daily basis? I'll tell you this, we have put together a way, one of the members of our team put together a way of kind of pulling in some of that federal data. We don't really want people to get reliant on it as a daily source that we maintain, but we'll have a link to that somewhere that would allow people to make that like fairly easily. And Peter can't help himself. That's one thing we've learned about him through this whole pandemic. I'm sure that Peter will make lots of very interesting charts that heavily influence how people see the pandemic, as he has been doing for the past year.
We're not going to commit Peter to doing it.
We're not going to commit Peter to doing that work.
We do have, I wanted to say, we have a post coming up probably early next week that will show how to do it and where the data comes from.
Mm-hmm. For those who haven't seen it, it's a great 4-pane. The testing data is difficult for various reasons to put into the format that you've been accustomed to seeing from us. But we have something else that we can use. We have cases, we have hospital admissions, current hospitalizations, and deaths that are fairly easy to pull in the way that you're used to seeing them from us, from the federal government, which is what that question is really about.
And you will see that chart in our weekly update, which is being published probably within the next 30 minutes in the analysis and updates section of our site, and then at The Atlantic.
Indeed. Thank you very much. We really appreciate all your time and attention to this, and we will be seeing you soon, I'm sure.
Thanks,
All
everybody.
right. Thank you.